The following podcast is part of a certified educational activity titled Conversations on the Emerging Wave of Targeted Therapy in Follicular Lymphoma, Understanding the Implications for Personalized Medicine. Access the entire activity and complete the post-test at peerview.com/EUU860. Downloadable slides and practice aids are also available.
Hello and welcome everyone. I'm Dr. John Pagel from the Swedish Cancer Institute in Seattle, Washington, and welcome to this panel discussion on the use of novel therapeutic options for relapsed refractory follicular lymphoma. I'm pleased to welcome my colleague today, Dr. Ian Flynn, who's from the Sarah Cannon Research Institute, to this discussion. Welcome, Ian. Nice to have you with us.
John, thanks. It's nice to be with you.
Well, let's get started. Let's get right into a discussion about the novel therapies in follicular lymphoma and what the landscape looks like, not just in the front line, but primarily in the relapse refractory setting. I think that, it's kind of been a revolution a little bit in the therapy of follicular lymphoma over the last several years because we've been able to incorporate a lot of new interesting agents, targeted agents, into our therapeutic regimens, and they've mostly been in the relapse setting. Of course, we recognize them by NCCN. In the frontline options, primarily we still use chemoimmunotherapy for follicular lymphoma when patients do have an indication for therapy. Most commonly in the United States, we're using bendamustine and rituximab, but certainly the combination with the type 2 glycosylated anti-CD20 antibody obinutuzumab with bendamustine is reasonable as well. We also recognize that in some patients, anthracyclines and R-CHOP might be important, or RCVP is still a very reasonable, important option for these patients, all as frontline therapies with chemoimmunotherapy. The relevant study, as you know, Ian, was an interesting study that used and explored the opportunity to give Revlimid or lenalidomide with rituximab, the so-called R-squared regimen. And while that regimen didn't show a superiority over chemoimmunotherapy, it did show that it was perhaps just as good. And in some ways, for people who can't get chemoimmunotherapy, it might be a very nice option for them. Obviously, we still use a lot of single-agent rituximab in certain particular cases. But one of the big problems that we have with follicular lymphoma is that the first remissions are obviously never going to be long enough. And when people do relapse, their remissions become shorter and shorter over time, or those subsequent treatment encounters or therapeutic interventions. So what do we do in the relapse setting now? Of course, again, if you look at NCCN guidelines, we can give more chemoimmunotherapy. Often that's probably not particularly appealing, especially when you consider that patients might be a bit older or have comorbidities and have seen chemoimmunotherapy in the front line. And that's why I think we should talk a little about the R-squared regimen in the second line or even later for patients with relapsed follicular lymphoma. Maybe we'll talk about the AUGMENT data here in a second, realizing as well that people will still relapse. Those are major unmet needs in these relapsed patients, in my opinion, because these people will have continually shorter remissions. So we need new novel therapies. Targeted agents have really emerged there. I'm excited about the ones that are coming along. We'll talk about those at the end of the program perhaps, but also recognize that we have PI3 kinase inhibitors as well. And we have now a new, interesting, very important targeted agent known as tazemetostat that we should focus on that targets an enzyme known as EZH2 that's critically important for B-cell biology, and in particular, the follicular lymphoma survival or cell survival. And if we can interrupt that with this new agent, tazemetostat, which again we'll discuss, will be very interesting and important for patients down the road. Let's do a bit of a case, Ian. I think this is important for us to kind of put this into context of the patients that we see in the clinic. And this is the kind of patient that really comes into the clinic, I think, in the community very commonly. This patient is Eric. He, at the time of diagnosis, was 68 years old. And like the vast majority of patients, he had advanced stage disease with typical immunophenotype characteristic of follicular lymphoma, CD10 positive, very highly expressing CD20 and BCL2. Of course, we don't treat patients until we have a good reason. But this patient did end up, because of indications perhaps of increasing adenopathy or symptoms, perhaps even bulky disease or cytopenias, needed some treatment and got bendamustine and rituximab. Most people are, going on to bendamustine and rituximab in the front line, and often will receive 6 cycles of therapy. Ian, maybe I'll just bring you in here and ask you, what's your typical kind of go-to follicular lymphoma regimen in a patient like this? Is it bendamustine and rituximab for you?
Well, thanks, John. Yeah, I have to say I do commonly use bendamustine rituximab as my first-line therapy for the vast majority of patients with follicular lymphoma grades 1 and 2. I mean, that's really based on the STILL trial as well as the BRIGHT trial, where we saw improvement in progression-free survival with bendamustine rituximab. There's still adverse events associated with it, but it seems to be more tolerable in my mind than what we see with R-CHOP. And so I've really gotten away from R-CHOP in the front line and use a bendamustine and rituximab for those patients predominantly.
Yeah, and I would say that that's my approach as well. I tend to reserve something like R-CHOP for those grade 3 follicular patients that have a more aggressive type of lymphoma. But bendamustine rituximab is certainly likely more well tolerated in many ways. Patients will do well with it. I have a healthy respect for the myelosuppression with the bendamustine, frankly, and so I don't like over-treating with bendamustine rituximab. I think that's an important message. And our patient here did get BR and did well, got a good remission, actually 3 years before, unfortunately, at the age of 71, his disease had now come back. So, this is a very common scenario. People will do well, but of course they're going to relapse, and that first remission is going to be, of course, where they get their most benefit. But now we have to think about what we do 3 years later in this patient. So, tell me a little about how you would approach this patient, Ian, when you see them in the clinic and they've relapsed after 3 years from first-line treatment.
Well, I think just to echo some of the things you said earlier, one, this is a relatively common scenario, right? I mean, the patient had a 3-year remission from BR. That's not the longest, but not the shortest remission duration. It's not a POD24, so it's not one of those patients who have those very high-risk features that you're overly worried about. And so this patient, by all means, should do relatively well with his disease over the coming years. Now, I also am a little worried about the cumulative toxicity of bendamustine, and so while he had a nice remission to it to begin with, I would not go back to that again because I'm worried about the merotoxicity and there's clearly an upper limit on those cycles that you can give people. And towards that end, I also would sort of try to avoid more chemoimmunotherapy. There are a number of more targeted approaches, non-chemoimmunotherapy approaches to this patient. He's now 71. Giving that patient R-CHOP, it's not the easiest thing in the world. Reserving it for patients who have transformations, as you said earlier, I think would be useful. So, I'm thinking more along the R-squared regimens or other targeted agents instead of chemoimmunotherapy at this point, mostly from a tolerance standpoint, as well as getting away from the adverse events associated with cytotoxic chemotherapy.
Yeah, I think you and I are pretty much on the same page there. I will say one of my messages that I would convey, of course, its opinion, but it would say less chemotherapy in this setting, not repeating bendamustine, although it can be done, often is perhaps a better approach. And so I'm very attracted to the lenalidomide and rituximab regimen in this setting. I think it's a very appealing approach with different therapies that are very well tolerated. And of course, that's all based on the AUGMENT trial. So maybe I'll spend a minute just reminding everyone about the AUGMENT trial. This was a very, very important trial for patients with relapse refractory follicular lymphoma. There were some marginal zone patients in there as well. These are people who had failed prior chemotherapy. It's important to note that these are people that could not be refractory to prior rituximab therapy. So they're sensitive to rituximab. But it was a very simple study led by John Leonard that randomized patients to the R-squared regimen of rituximab with lenalidomide versus rituximab alone, or rituximab with a placebo. And you treat up to 12 cycles or until progression or intolerability. And so a very important option that's not chemoimmunotherapy for these patients. And I think one of the major things to note is that while the regimen is very appealing in that it's not chemotherapy based, we still do see important reactions, or I should say adverse events, that we have to recognize, and they're primarily related, of course, to the lenalidomide. So you have to watch for infections. You can see with the R-squared regimen, you may have a few more infections, even some more grade 3-4 infections compared to single-agent rituximab. Certainly going to have some more cutaneous reactions or rashes or GI distress, maybe a little bit of diarrhea or constipation. But in general, you can see that most of those adverse events with the R-squared regimen are grades 1 or grade 2. Very few relatively are grade 3-4, except for the neutropenia. We do recognize that the neutropenia will be more significant with R-squared versus single-agent rituximab. But I'll also remind you that this agent doesn't typically cause mucositis, so you don't get translocation of bacteria across the bowel wall. So the infections are not those that end up causing patients to be in the hospital with bacteremias. They typically will do well. And of course, I'm pretty sure that the audience is well familiar with lenalidomide and its adverse events. So none of this is really new or surprising. We're pretty familiar with the drug when we use it for myeloma. So clearly, it's something we likely feel very comfortable with. I know that I do, and I really do like it in this space, in particular in the second-line therapy. And I will say what's really important is the potential for significant opportunities to prevent or delay relapse, progression, or even death. And that's related to the augment progression-free survival curves. This is, of course, taking into account some marginal zone lymphoma patients as well, but the vast majority of them did have follicular lymphoma, and it did show that this R-squared regimen had improved PFS compared to single-agent rituximab alone. You can see there was a median PFS estimate of over 3 years with R-squared. Frankly, it was about a third shorter period of time with single-agent rituximab. So often what we're seeing, and I clearly do, is that when I'm thinking about a patient where I might have used single-agent rituximab, the opportunity to add lenalidomide to that patient is something I want to consider and recognize that this regimen, R-squared, gives us about a 54% reduction in the relapse, progression, or death risk compared to single-agent rituximab. So I think this is a really nice option to consider early in relapse, could be later, but it's not chemotherapy. So it's a chemotherapy-sparing option for these patients. Clearly appears to have a significant improvement in PFS over rituximab. We want to watch for neutropenias, infections, and certainly dose adjustments I think are very important when we use lenalidomide. I actually will commonly have people at 10, 15 milligrams, even sometimes 5 with lenalidomide doing very well with their lymphoma. I think it's important, of course, to recognize that we're palliating these patients and we're hoping to keep them happy and healthy for as long as possible. I do often use growth factor support. That's the GFS there. Of course, we're going to see some, again, neutropenia. And we're going to want to, of course, prophylax with some agents such as an aspirin against thromboembolic events. So that's all important and relevant to using the R-squared regimen. So that, Ian's what we did here in this case. We gave this patient in his first relapse after a 3-year remission R-squared. Again, some thromboprophylaxis is important. Don't forget that. You're delivering the lenalidomide 21 out of 28 days, 28 days being a cycle, and you do that for a year. This patient, again, got a very good response and did well, did have some neutropenia, and did, as I've said, get growth factor support. The problem, of course, is that, again, he relapses, and he got almost 1.5 years of a remission. Hopefully he felt well and did well during that time. Now we're talking about Eric being about 73 years old, and now he's coming back in with some suggestive signs or symptoms of progression. And clearly he's relapsed at this point. So Ian, I guess I'd love to hear from you about what you do in this setting. This is not an uncommon situation, I don't think. So what are your thoughts here?
Yeah, again, I think you're right. It is a very common situation. This patient's remission lasted about half of what he did for this first remission. And so, once again, he's in a point where he likely needs treatment again. And so there are a variety of options from the PI3 kinase inhibitors, the EZH2 inhibitor. You could consider going back to more rituximab and R squared, but I think the PI3 kinase inhibitors are an important option at this point.
Yeah, I would say for me, again, I start thinking about novel therapies, different mechanism of action, people becoming more refractory to rituximab at this point. Eric's probably seen a fair amount, definitely has over the last 2 different regimens. So I do like the idea of PI3 kinase inhibitors. Ian, you have a lot of experience with them. Why don't you share with us some of the data around PI3 kinase inhibitors in follicular lymphoma?
Sure, John. Well, let's first start out looking at the pathway of the PI3 kinase inhibitors. I think many are familiar with this. The PI3 kinase kinase plays a pivotal role in the variety of cell surface signaling events that lead to B-cell proliferation and survival. And so, the theory is here that if you inhibited the PI3 kinase, you might lead to cell death and B-cell malignancies. And there have been a variety of 4 different drugs FDA approved for the treatment of follicular lymphoma. The first was idelalisib, and then we've subsequently seen others. We also know with the development of idelalisib, there are 4 different isoforms of the PI3K, alpha, beta, delta, and gamma. Idelalisib is a pure delta inhibitor. This is attractive because the delta isoform is limited in expression to cells of hematopoietic origin, and therefore, if you inhibit only that isoform, you may not get some of the off-target toxicities that you see with an inhibition of some of the other isoforms. And that was the hypothesis behind idelalisib, and I think largely has proven to be true. There, of course, are some toxicities, adverse events that we'll go through, but we know from gene knockout mouse models that there can be autoimmune complications, predominantly colitis, that is seen with the inhibition of the delta isoform. Well, idelalisib, I said, was the first to be approved. This is from the pivotal phase 2 trial. You see the waterfall plot across a variety of different histologies, and clearly very active in all the different low-grade B-cell malignancies. Duvelisib, this is the Dynamo trial. It was in a very similar trial that was conducted with idelalisib in what was called the double refractory patient population, refractory to both chemotherapy as well as rituximab. Again, I think very similar response rates and duration response as well as was seen with idelalisib. Copanlisib, again, is a little bit different. It's an IV drug rather than an oral drug, and so its schedule is different. It's given on days 1, 8, and 15 of a 28-day cycle. It too was tested in a phase 2 study of 142 patients. Now, in this patient population, they weren't double refractory. They just had to require two prior treatments. But here we're seeing the waterfall plot. If we concentrate on, for today's session, on the follicular lymphoma in blue, but again, we're seeing an overall response rates of more than half of patients, and median duration response of 14.1 months. So if we look on this slide, we see that the duration response is 14.1 months, and overall survival is also quite good in this patient population. Of course, patients who have who achieve a complete remission, as is true with most drugs that we test, do better than those patients who have a partial remission. But these are the outcomes as listed here. Now, copanlisib has also recently been reported, and we've only have really the press release at this time, but in a confirmatory trial, randomized trial of basically rituximab plus or minus copanlisib. It was a placebo-controlled trial, and this study met its primary endpoint of improvement with the PI3 kinase inhibitor. So we look for the full results of this to be published. Now, finally, we did see at ASH 2020 the new kid on the block. This is umbralisib. Umbralisib, as you remember, as I mentioned, is a pure delta inhibitor. It's an oral agent. The phase 2 Unity trial led to the approval of umbralisib in patients with follicular lymphoma. Here we're showing that cohort of the overall response rate of of 45%, and a minority of patients achieved a complete remission. These are the progression-free survival curves. The darker blue color here is those patients with follicular lymphoma, and patients with marginal zone and small lymphocytic lymphoma were also accrued to this trial, and it has led to the approval in patients with follicular lymphoma who've had 3 or more prior lines of therapy. So another important agent to add to our armamentarium. Now, I think one of the issues with PI3 kinase inhibitors is not necessarily their efficacy, but has been the Achilles heel has been some of the adverse events that we see. Starting really with idelalisib, and again, I mentioned in the mouse models, there was predicted that there would be colitis and some autoimmune events, and we did see that with idelalisib. It's also seen with duvelisib, lesser degree, I think, with copanlisib, but also, and probably a little bit less with umbralisib. But it's present across these different PI3 kinase inhibitors, and people really have to be careful about looking out for these adverse events in your patients that you treated. Of course, you're going to want to look out for infectious complications in this patient population and across the different the diseases. And some of the management of these AEs is listed here, but a lot of it's common sense. When you see someone who has a significant adverse event, you're going to hold. You're going to wait till that's resolved. You're going to reinstitute the therapy, perhaps at a reduced dose that's more tolerable. The one difference, again, I mentioned was copanlisib. It has hyperglycemia and hypertension. You're going to particularly worry about patients who have previous history of diabetes or hypertension, but for most part, this is a transitory event, and most people get over this within 24, 48 hours of the infusion.
Yeah, thanks, Ian. I think that was a great discussion around PI3 kinase inhibitors. I still use a lot of PI3 kinase inhibitors. Of course, you and I see a lot of follicular lymphoma patients who have relapsed, but the problem that I've always had is the adverse events, the toxicity, those immune-mediated events that you talked about. So I'm always excited to use a PI3 kinase inhibitor because I know I'm going to get some good efficacy, but I have to be very cautious about it. And that's why I'm excited about the idea of incorporating even other agents that are options for patients in that setting. And let's come back to our case and do a little bit of that. Remember, Eric, he received BR and then R squared, and now he's relapsed about 16 months after lenalidomide and rituximab. He's got clear progression. And the idea now is to think about other therapies. Certainly PI3 kinase inhibitors are important, likely discussed with this patient, but the toxicity profile of the agents may have some concern for him. He is now in his early to mid 70s, maybe with some comorbidities. Of course, the majority of patients in that age group will have comorbidities. So it leads us to explore the newest option for therapy for this patient with relapsed disease, known as tazemetostat. But let's first talk about tazemetostat and its role of targeting EZH2, not just EZH2 that might be mutated, but also wild-type EZH2, where the drug has significant activity. So it has activity, again, both in wild-type and in mutant EZH2 cells. And that's critically important to remember because EZH2 biology, as I've said now, is very important for keeping the B lymphocytes locked in the germinal centers, this germinal state of the normal B cell development. So if you can release that so-called kind of lock on the germinal state, you can allow for these follicular lymphoma cells to not only progress through the germinal center, but end up going on to apoptosis and allow the next cells to come along. So unlocking those follicular lymphoma cells that are kind of embedded in a proliferation state and an anti-apoptotic or an anti-death state. And we can do that again by targeting EZH2. Again, even wild-type EZH2, but I will also point out that about a quarter of patients, maybe a little bit less, will have gain-of-function mutations in EZH2. And clearly, if we can inhibit that gain-of-function mutation, we can induce cell death. So the drug tazemetostat was looked at and now has been approved in relapsed follicular lymphoma patients based on this single-arm phase 2 study. This was a study of a modest number of follicular lymphoma patients were of course, treating more patients in larger numbers on other trials now, but this early trial looked at tazemetostat. It's 800 milligrams delivered twice a day. Again, it modifies the epigenetic changes and gene transcription in the germinal center by targeting EZH2. And this study actually looked at an important population of wild type as well as mutant EZH2 patients. While I won't go through everything on this slide, I want to point out at the bottom left that the median number of prior therapies were different in the two different cohorts of patients. So 2 in the mutant population, 3 in the wild type population. The median age of the patients here was in the early 60s for both cohorts of patients. Now, I will tell you that lots of people will do very well with this drug, even who are in their 70s and 80s, but the oldest patient in the trial was in their upper 60s. And these are people that really, really needed treatment. These are people who are in their third line or later. And you can see that many of them were refractory to prior rituximab-containing regimen. There was even some grade 3B patients in this trial, which is very unusual, as you know, to see in relapsed follicular lymphoma trials. And there were some patients who had failed a prior transplant. Actually, almost 40% of the wild-type patients had failed an autologous stem cell transplant. That's a very difficult patient population, including some with double refractory to an alkylating agent and an anti-CD20 antibody. So a difficult patient population. And if you look at the efficacy, here a waterfall plot for the EZH2 mutation patients, you can see that those patients do extremely well. Really, everyone's having reduction in their tumor burden. And many of those people are having significant documented objective partial remissions or even complete remissions. Unfortunately, not everyone is EZH2 mutant, as I've said. So the wild type population, again, a more heavily treated population than the mutant patients, and importantly also very high risk patients can still significantly benefit from tazemetostat. And you can see that here from the waterfall plot. Many people will have responses. And actually, there are many people that are not achieving that 50% reduction in disease burden, but are having tumor burden reduced. They have so-called stable disease that are likely benefiting from the therapy. And importantly, this translates to significant opportunities for meaningful progression-free survival in both the wild type and the mutant cohorts. And so you can see that here based on the PFS in the two different groups. It's about a year or so in both, a median of 13.8 months in the EZH2 mutant cohort, 11.1 months in the EZH2 wild type cohort. So before I give some closing comments on tazemetostat, Ian, I want to bring you back in and ask you your thoughts about tazemetostat and EZH2 inhibition and where you really find this regimen, this agent perhaps appealing or not. What are your thoughts around where this might fit for our patients?
Yeah, I mean, I think my thoughts have really gone through an evolution with tazemetostat. I mean, arguably the safety profile is excellent. The results are very similar to the PI3 kinase inhibitors in terms of efficacy, and so I am really I think these are great results whether you're wild type or whether you're a mutant. I think that increasingly I'm using this in this very patient population that's after the R-squared regimen. I'm moving to this perhaps before I use a PI3 kinase inhibitor because of the improved adverse event profile. So I think the results are excellent, frankly.
Yeah, I'd say that's where I fit on this too. I think the most appealing part of this therapy is not the efficacy. The efficacy does speak for itself, but it's the tolerability of the agent, which I haven't really discussed. But the rates of grade 3, 4 adverse events are almost non-existent with this therapy, as you're kind of alluding to. Completely different than the PI3 kinase inhibitors. And for me, in a patient population where I know I'm not going to cure them, I love the idea of giving them something that they're going to tolerate very well. So this is emerging for me as well, something that is becoming more appealing. And I will point out that it's approved essentially for any relapsed follicular lymphoma patient. Now, the indication, the label from the FDA is a little bit tricky, but as you can see, it's approved for patients who have relapsed refractory follicular lymphoma, and for those who have an EZH2 mutation who have failed at least 2 prior therapies, or or I should say, and it's also approved in relapsed follicular lymphoma patients who have no satisfactory alternative treatment options. So those are including the wild type patients who you may not want to give a PI3 kinase inhibitor to, or sometimes maybe you're not even attracted to using R squared in a particular patient, perhaps because of cytopenias or so. So it's really approved for any important relapsed follicular lymphoma patient, whether they're wild type or mutant. And that leads again to the last comment about testing. You can test for EZH2 mutation, and I do it, and I like to do it, but it's not required. Again, you can treat both wild type and mutant patients without knowing the mutational status of EZH2. It is a next generation sequencing test. You do need tissue. You have to use archival tissue often. That's okay. It's important to do that if you want to know the results. But again, I want to be clear, you don't have to test if you don't want to, because you can use the agent in wild type patients, especially if you consider there's no satisfactory option for therapy, where you might want to use it even a bit earlier. I think the beauty of the drug as well, just in closing, for me, is again the tolerability. This has, in my experience, been the perhaps most well-tolerated single agent that I've ever used in relapsed follicular lymphoma in my 20 plus years of using therapies for follicular lymphoma. And that really leads to this idea that what we're going to be able to do is use tazemetostat in combination with other agents or other regimens. So it's being looked at in a variety of those, including even the frontline setting, but it's also now looked at in a very pivotal randomized phase 3 trial in relapsed patients, either with Revlimid or lenalidomide and rituximab, the R squared regimen. So it's R squared plus or minus tazemetostat for those relapsed follicular lymphoma patients, and we'll very much look forward to those results. So I think we've given you, and I hope we've done well, a nice practical synthesis of how we approach these patients and where even these targeted therapies and now this new agent, this epigenetic modifier, fits in relapse refractory patients. I might just spend a minute just talking about the emerging landscape and the novel therapeutics in follicular lymphoma. We do understand that now we have these chemotherapy-free options. We still want to be able to recognize that these agents are important, but people will still relapse, and we need to, of course, continue to improve on our options. We have R squared, we have the PI3 kinase inhibitors. Now the recent addition of umbralisib may be an advance in that class, and I've just mentioned tazemetostat as this low toxicity epigenetic modifier. But do know there are many agents on the horizon, and in particular, I just want to briefly mention bispecific antibodies. Hopefully you've heard a lot about them. I think they're very exciting. They're off the shelf. They're easy to deliver. You can deliver them actually repeatedly in the right patients, and they're an idea of actually targeting CD20 on the lymphoma cell and CD3 on the surface of the cytotoxic T cells. So these are bispecific engaging antibodies, or the BiTEs. The lead one that we've seen a lot of data on is mosunetuzumab, a very difficult patient population with relapsed lymphoma having complete remissions. It's going to likely be important in relapsed patients, and there are a variety of others in development. You can see those there, and we'll look forward to that additional data emerging over some very immediate future. And then lastly, no CAR T cells are on the horizon for follicular lymphoma, and they have the potential to be a major game changer in the natural history of this disease for the right patients. And if you look at the data presented at ASH 2020 by Karen Jacobson in the ZUMA-5 trial, CAR T-cell therapy using axi-cel for relapsed refractory lymphoma, and looking at the follicular patients, an over 90% overall response rate with a very high CR rate. We need to follow these people for a longer period of time to see what happens with relapses, but we're very encouraged by this approach, and we'll look forward to seeing where it fits very soon. Well, I want to wrap up the program. Thanks for joining us. I think what you've seen is that we have a variety of options for these patients with follicular lymphoma. These patients have relapsed after standard chemoimmunotherapy, and thus we like these novel modalities that are really important and are emerging as well in development. I think it's worth noting that many of these strategies are importantly chemotherapy-free. And that's great news for our patients. Ian, I'll thank you for participating with me today in this discussion. I hope you enjoyed it, and I know that I did. And thank you everyone for joining us today. I hope you found this program informative and useful for your practice.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/EUU860. This activity is supported by educational grants from Bayer Healthcare Pharmaceuticals Incorporated and Epizyme Incorporated.
This activity is accredited by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.